Now, in this PowerPoint, we will discuss venous ulcerations of the foot. These are relatively uncommon, but when they do occur, it requires more investigation with the ultrasound to determine the etiology. The treatment also is somewhat different in the type of compression that we apply. Ulcers that occur on the foot, as mentioned before, are relatively uncommon. Now, three factors acting synergistically form the perfect storm for foot venous ulcer formation. This is superficial saphenous reflux, usually the GSV, a large first metatarsal perforator with flow occurring from the deep to the superficial system, and an ineffective foot emptying of the venous reservoir. We'll talk more about this lately, but when you see these three factors in combination, you may get ulcerations of the foot. You can also get ulcerations of the foot in some cases with obstruction of the deep venous system. The history in this patient is an ulcer duration of 1 year. 5 previous consultations with doctors, purportedly vein specialists, no recommendation of compression, no associated comorbidities except skin cancer on the ankle area. He takes only medication for mild hypertension. He was told to wash the wound with a mild detergent solution, and he was using honey on the wound, but no compression. Now, the ultrasound revealed GSV insufficiency greater than 3 seconds, the entire length of the vein. Marked stasis changes were around the ankle. This is also the area that the patient had a previous resection of skin cancer. The GSV measured 8 millimeters. The perforator, the first metatarsal perforator, measures 6 millimeters, and there's pulsatile flow in the perforator. Now, when we see pulsatile flow, we usually think of proximal obstruction or high pressure, or possibly ASD. I have seen pulsatile flow many times in patients with benign cable compression. I've also seen it in patients with atrial septal defect. In fact, years ago, I diagnosed an atrial septal defect in a patient who had pulsatile flow in the femoral veins. But anytime you see pulsatile flow, there is pathology in the venous system, either functional or mechanical alteration of outflow. There was no Bruyne auscultation of this area, so there's no AV fistula present. You can see the metatarsal artery, which is actually the last branch of the dorsopedal artery in this ultrasound as well. There was normal flow and no reflux in the deep venous system. This has been here for about a year, this ulceration. You can see right here, when he puts his foot down, it's very dilated, and there's a perforator that comes up right here, and has a lot of flow into it. I'm going to show you that on ultrasound. Now, this is a venous anatomy of the foot. This is from Dr. Stefano Risci's paper. I have a link to this at the end of the presentation. But you can see here the first metatarsal perforator. It connects the lateral and medial plantar veins, the dorsal venous arch, to the marginal veins, which are the lateral and the medial. In this case, you can see the flow is from the perforator, which is labeled number 8. It goes up to the medial marginal vein and then goes into the greater saphenous vein, number 3. So in this patient, we had pulsatile flow, which means there's probably proximal functional outflow obstruction, either from high pressure in the greater saphenous vein or incompetent foot muscle venous pump, or both of them. It's really difficult to tell without doing sophisticated studies, but when you see pulsatile flow like we talked about before, this has to be transmitted from the proximal area, either by functional or physiologic obstruction. The arrow points to the area of the ulceration. So this patient has almost a type of a closed circuit system here. Possibility, and that the flow goes up into the marginal vein, to the greater saphenous veins, back into the perforators. And then there may be pressure, higher pressure in the posterior tibial vein, and then decreased outflow through the lateral marginal vein. So in essence, what we have here is a lot of flow increase in the foot and a high pressure approximately in the greater saphenous system. And this may be the etiology for this ulceration of the foot. Now here's the perforator again. We're showing you. It's got a lot of flow in it. I injected this vessel right here with foam, and it's occluded. We use 0.3% Citrodecol, and this leads right up to the ulcer base. So it's an excellent result. Now we're going to show you the wound, how we're going to treat it here in just a second. Okay, so we just debride this a little bit by gentle washing. You can see, get some of this off. Every day you use a pressure from a shower just to help debride this. Wash it with dial soap. We're just going to put a Telfa pad. You can use a little Silvadene here too, just a little bit, and we will in a minute. I wanted to show you this, that we're going to put this just like this, and then we're going to wrap it. Okay. Now, foot ulcers require more thorough investigation as to etiology. In this patient, our next step will be intravenous ablation of the GSV and obliteration of any subsequent reflux in the lower GSV if needed. Now, by lowering the superficial pressure, we may increase the outflow in the foot. That's our objective. It's really difficult to determine the foot muscle pump, how much this contributes to the pathology, but we do know we have pulsatile flow in the metatarsal perforator. This may be secondary to increased pressure in the superficial system, since it's connected to the superficial system to the marginal vein, or it may be due to ineffective outflow from the foot muscle pump. In this patient also, we did the tears technique. This can be done locally to decrease the venous pressure at the skin level. This is what we do first to see if we can promote healing, but other steps must be taken to effectively reduce the hypertension in the venous system. When compression is done, we make sure that we apply pressure, as we've shown you, over the perforator, and this is incorporated into the wrap. Now, this article by Dr. Stefano Rishi, is an excellent source of information on the venous system of the foot, the anatomy and physiology, and the clinical aspects of the foot venous pathology. I recommend you read this article. It gives you a lot of insight into some of the problems that may occur when the venous flow is altered.